if you allow for the next 10 years to have these systems, because industry is still putting pressure to keep the old system running, you can imagine pharmacy, other market forces. So if you don't make the choices there to change to the new way of working, then it's not going to succeed. So are you prepared to make these choices? Yeah.
Yeah, I think this is really important, and it's the route we're going down in Scotland, which is very similar to that Peter's articulated. That what we see at the moment is that our public services are increasingly expensive, and they're very expensive because we employ lots of people, and we actually have got the best terms and conditions for employing these people, both in terms of salary, entitlements, and pensions and so on. And that's just our reality. I'm not saying whether that's right or that's wrong, but that is our reality. But what we did is very similar to what they did in the Netherlands. Is we actually went out and surveyed the citizens of Scotland and asked them what their expectations were going forward, and particularly as it related to technology. And what they said was they wanted to be less dependent on, and these were health questions, so less dependent on the health system and healthcare professionals than they were at the moment. They wanted to be able to provide care for themselves if they could. Secondly, they wanted to care for others, and that was particularly true when they were talking about families. But they found it difficult to do so, either because their elderly parents lived at a distance, or that both partners in a relationship were in full-time work, so they were time poor. And they felt guilty about the amount of time they would have to provide care, which couldn't be enough. But thirdly, is the citizens of Scotland wanted to give something back, but didn't know how to do so. So if you actually think of, as Peter said, you've got technology solutions that can allow that to happen. You can provide information and advice, readily accessible in a form that people can access, to allow them to make decisions about managing their own health and care. So that's from prevention to promoting well-being to managing your long-term condition. You can actually provide that support, information and advice to carers, because the vast majority of times that carers opt out of that role is not because they don't want to do it, is that they find it is increasingly stressful and very difficult. They're more frightened that they may be doing harm in caring to someone, and therefore they stop doing it. Whereas simply giving them a reassurance to say, yes, you are doing the right thing, that is okay, will allow people to continue. So technology can help there. But thirdly, you can also then speed people into the system, actually, if they need to get into the system quickly. So we're designing a product which is the largest, we believe is the largest co-production process in the UK, if not in Europe, where we're designing a solution web-based by 3,000 of our citizens are working with us, which actually does that. It's designed to unlock the knowledge, experience and expertise that we all have inside us as individuals, and make that available to you yourself to manage your condition. If that doesn't allow you to solve your problem, we will signpost you to resources within your community where you can get the solution to your problem. And only if that doesn't work will you enter the formal health and care system. But if your solution is only in the NHS or in social care, we'll speed you to that point. Now that actually reduces cost, it reduces burden on the system, but it empowers individuals and their families to take a more active part and responsibility. And what we've found over the years, and I'm sure everybody involved in health and care know this, that we, in the mistaken belief that we're helping people, we disempower them by taking away that responsibility. So your problem is thrown to your doctor, who fixes it and throws it back to you, and puts you on a treadmill and gets really upset when we find out you're not grateful for what we've done for you. That is our reality. Now that's not a sustainable system going forward. And technology is part of the solution. But it's not about engineering carers, doctors and nurses out of the system. It's about making them more available to those people who need them where and when they need them. But a lot of the public think as soon as we talk about technology, it's about sacking doctors, it's sacking nurses and getting rid of the care. We need to position this in the appropriate and correct way. And that's getting people to use it as you're doing in Eindhoven. Yeah. You've got to touch it and see it, so as it demystifies it.
Very good. Okay, Lee. Yeah. question for you. So I'm interested in the Open Innovation Network, and that's the right approach. You touched upon a public-private partnership, which is a legal entity which you can sign on behalf of. What does that look like, and what was the first project or the first deal it did?
That's the Open Innovation.
Yeah, well, if you want, as George already also mentioned, you have to have a kind of a certain base and body in your organization if you want to move forward. So we said it cannot be a free ride, let's say a kind of membership, and you only pay like 150 euros and you're entitled to all kind of publications and events. So there is quite a high entry fee to commit, and it's also meant to make sure that you are committed to the joint agenda you are putting forward together. So that was the first step. The second is that if actually my members, I have 70 members, it's a cooperative structure, it's a legal entity in the Netherlands, actually they decide where we are moving and in what type of directions we're moving and where do we put our efforts first. So it is not about a small team designing the world, inventing the world from a kind of a crystal office and then shedding in a kind of top-down way these projects. And so it's more or less the bottom-up approach. So we sense what is where are the basic needs, the most urgent needs within our membership organizations, and they're all related to the healthcare spectrum. And that is the agenda I draw back, and then I'll try to translate it into our relevant initiative. So it's like inverting society, as is happening in many instances. I think that's the right way to make sure that you have a very flat type of organization, which is very mean and lean. And the second is, we don't drive these projects, so it is always a coalition of my member organizations who are in the project lead. So I can facilitate designing a project proposal, but eventually if the European Commission or anybody grants us some money, it is always 1, 2, 3, 4, 5 of our members together. So I have a business owner for any initiative we take, and it's never my responsibility because it's their choice, it's their commitment to make sure that by the end of the day they're also going to use the outcomes of these projects. So these are some basic principles which takes it the other way around in the way you're driving a new type of organization.
Okay, thank you. That was interesting. A couple of questions over here. One behind and then Maurice. Those perhaps we'll take a couple.
Yeah, that's great. Well, really interesting. We talked a lot. I agree with your description about how things will accelerate as more and more things become connected. What I didn't hear, and I suppose one of the challenges we've seen in America with them being able to use that, is there's lots of data coming from this, which will also be for the professions, actually, and for the companies and the private, help speed up the process if we have the access to that data and in that connected way, really enabled. I didn't hear how that was enabled within your partnership, but actually I would say any partnership is a critical part of it because it keeps speeding up the next set of innovations, the next How did you address that challenge?
Well, that's a very interesting and a very difficult one. We are struggling to find the right legal framework to define to what extent what data is open, because if you download an app on your iPhone for free, then you already agreed that at least 60 organizations are entitled to the use of that data without any further consent. We have a very specific differentiation between formal care, where we have a clinical care pathways, or they're regulated by our National Health Service, and then in the social care environment, it's even getting more difficult because that's the open environment where there is much open data. If you use a tracker for your personal condition or counting your steps or calories, that's just in the open space. You can put it in Microsoft Health Vault or any type of cloud type of solution, but it becomes very interesting if you then progress in your disease and become a formal patient, and then you are interested to share these informal data from your health tracker with your formal care provider like your GP, and then these two worlds have to face each other. So we are now, not our organization, but we are in a joint initiative to make sure that there is a kind of independent regulatory body who is more or less managing the exchange, the regulated exchange of data, both in the formal and the informal care space, and also defines the way where these two worlds can meet each other, and where exchange of data in an anonymized way is still allowed for, like, let's say, research and other purposes. But that you can have a workshop on that for the rest of the evening and the rest of the week, because then you become into privacy legislation as well, and it's a very, very complex arena. The easiest way, just make sure that you're only delivering consumer products with a CE marking without any type of medical device certification, and then you stay away from that for quite a long time. Yeah.
Is our GP voice, Morris?
Yeah. Yes, sorry. Well, given we're in Liverpool, it would be remiss of me not to mention the Liverpool My programme, which is a Dallas-funded programme. So here in Liverpool, we are a centre of excellence. We run the European Innovation Partnership reference sites, and I think it's worth making that point. Because we can come here to see what we're doing. We've already got hundreds and hundreds of patients being touched by this technology. Coming back to this, the health inequalities conversation, that technology is across the whole city. It's not in any one area. So it's being delivered through the geographies with a central hub. Advert over. One of the other questions we just talked about was data, and I think it's worth sharing what we're doing in Liverpool as an approach, which is trying to develop a patient health record and have a common platform, and then people can lay their own technology, their own apps onto that, and that will suck through data, and it will put the patient in control of it, and we'll then have less of an issue about how it can be shared, because the patient will be able to share it themselves with whom they wish. And I think that could be quite a powerful thing. Question though, the NHS is a different world to the commercial environment and the market environment that we find in the Netherlands. So I'd be interested to hear your perspective on how to deal with the NHS as a beast, if you like, as an entity, which is one thing, versus a market. I've got some answers, but I'd like to hear your answers.
And George might come in on that one as well, I would think.
First of all, let me state that it was Liverpool with their initiatives which more or less cleared our mind that we have to take a kind of consumer approach in the whole way we look at these new systems. It was Liverpool who had an initial idea about putting a kind of a retail store here in the storefront where you could, as a consumer, feel and touch these new innovative products and also perceive the way they could contribute in your proceedings, in your healthy life. So it was the direction of thought which we very thankfully learned from Liverpool. Eventually now followed by many consumer brands. If you go to a media market or a retail store, then you will see what's happening right now. Back to your question, by delivering proof on a regional level with a significant number of clients, patients involved, has brought us to on the discussions on the table with our national health, so because we still have a national health ministry, which still can be considered as part of your NHS as far as legislation is involved. We now see that they are more and more also inverting the model. So they take the outcome of regional changes in the way we organize and deliver care. They are more and more start to adapt that in the way they are redesigning their policy. So I think we are more or less changing the way knowledge and also redesign of new health policies is taking place. And it helps that our national ministry is under budget pressure as well. So they are more or less refraining from all the deployment initiatives, and they get back only to the legislation and the policy side. And that's where we, again, like we do with Brussels, we offer them the helping hand. So we're already offering them the policy for the new pathways of health surrounding these chronic or other conditions. So more or less we offer them to help them redesign the system, and we put in a lot of effort and money to make sure that they also do the legislation change in a way that it suits the possibilities and the needs of these new technologies. So that is where we have a very active approach from a regional level to our national health service. Of course, you can look at these instances in very different ways, but then I only consider them as a customer because they have to serve my needs in the way they have to serve the change we need. So that's a kind of another type of relationship we are developing from not only from the Eindhoven region, but from other leading regions in the Netherlands are participating in the same change space. Yeah.
Okay, come on, George, on the private-public interface.
Well, very simply, I mean, the NHS is a horrendous organisation for any company to do business with, particularly if you're a small and medium-sized enterprise. It's nigh impossible. Example, we've in the digital health and care space, we've got about 600 companies in Scotland. the vast majority of them make the vast majority of the money outside Scotland. They don't sell into the NHS in Scotland at all, because they can't. Because the way we procure most of our stuff precludes them at the first hurdle, because they can't pass the financial test. So we have, in technology terms, the Atoses, the IBMs, the names we all know and love selling the usual crap to us, and it never moves the world forward. That is our reality. So the thing about innovative procurement and about SBRI with TSB, which you've done here, we're looking at that as new ways of energising that market to try to actually grow the economy at the same time as addressing those challenges. And I think the new European legislation round about procurement has helped that. And the fact that the UK has been one of the early adopters of that. But the issue is that the most conservative and boring people in the world are NHS. Oh God, are there any NHS procurement managers in here? No, thank God. Well, they wouldn't get out after 6 o'clock at night because they don't have a life. They are the most conservative, no risk-taking people you would ever meet. And that's a problem, because although the legislation has moved on, although some of the barriers aren't there, we still aren't moving as fast as we should. And we've actually got a responsibility to these companies, because we're investing a lot of public sector government money in encouraging them down the track. If they had the NHS stamp of approval in that they pilot and at scale deployed, as Peter's been doing in Brabant, they could then sell into global markets, because that would get you through the door. But we don't give them the opportunities they need. But we always fall back on the 2 or 3 really good examples, and we tramp them out as though we've got it sorted. We actually haven't. Until it's the way we do business on a day-to-day basis, we still have to work hard at this, and we're not there.
No, that's very helpful. I think we better just take, I think colleague at the back wanted to come in, and then we probably ought to draw it to an end, I think.
You mentioned how technology could empower healthcare and health. But how do we ensure that we don't just empower the worried well, and that actually the unworried, unwell are also empowered, because they're the people who probably access healthcare least appropriately at the present time, in places like Liverpool and Glasgow?
Okay.
That's a good final question, I think, for both colleagues to come in. How can we tackle health inequalities within this agenda? Yeah,
Okay, let me answer that very briefly, but in 2 ways. The first way is, the vast majority of e-health and technology improvements since 1948 to date have been designed to benefit 2 sets of people: organisations and the health and care professionals that work in them, not to benefit the patient or the citizen. That's a fact. Secondly, it's not about the technology, it's about the service design and redesign. And that's the one that will address your issue. We've invested a lot of time and effort, certainly in Scotland, and I know you've done that here too, in actually understanding how to redesign services and putting the citizen at the centre of that. But a lot of the time we go around Europe, we hear this person-centred care, but when you lift the stone and look to see what person-centred care is, it's no more person-centred than fly in the air.
Yeah.
So it's about getting the design right, making sure the technology that wraps around that is appropriate and easy to use. 95-year-olds can use technology if it's designed in a very simple and user-friendly way. So for me, that's what it's about. And we often get it wrong, and we always say, oh, it's the technology, it's the problem. It's not. It's the people who've designed that wraparound.
That's very helpful final point from you, George. Peter?
Well, I think I only pointed at the screen. I mean, in our experience, people from different social profiles, either be in a high-risk profile or in a low-risk profile, high and low educated, as long as it is the way you can use it in an intuitive way, as a smartphone is designed, I mean, that's the best guidance in taking bear in mind if you look at the service redesign George mentioned. So if you can use it without using any, I mean, who is using a smartphone and still reads the instruction manual? It's not even no longer delivered with your smartphone. So if that becomes the pace of technology, and it's not the technology, but it's the user interaction, it is also the user experience you're then providing. If it is on that level, you can be sure that even my mother, 80 years, is using her iPad for these kind of applications, and that's not and it's not for the next generation. It's still for the generation we're still serving, 65 plus, who are definitely going to use a big part of these new possibilities. Yeah.
That's great. Well, I think we'd better draw this to an end. Thank you all very, very much for coming. If you're not having to rush off and chat, please do so. But as we're run over time, thank you for coming. And really enormous thanks to George and Pete. I think another round of applause.